Hello, I'm Ross Camidge. I came on my scooter. This is Helmet here.
You have a scooter?
I do. You
Oh,
know
that's
that.
fantastic.
Okay,
I'm
introduce yourself.
I'm Erin Schenk.
Erin is a double threat. She is a physician and a laboratory scientist. I am only a physician. Hello from Casey. Okay, thank you. So yes, we can't see you. You can see us. It's a very one-sided relationship, but we can see your questions if you put them in the chat.
Or questions and answers, either one.
All questions and answers. Chat's better because it scrolls.
Yeah. Mm-hmm.
So this is question and answer. So if you don't ask any questions, there are no answers.
It might be dangerous. We might just chit chat amongst ourselves.
Oh, when do you recommend consolidative therapy? Oh, let's do them one at a time. Okay.
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 All right.
So you treat someone to the point of maximal response, which is traditionally defined as 2 scans that look the same. My personal preference is to make one of those scans a PET scan so that you really can assess that there's not very much stuff left. And then I go to the radiation oncologist and say, don't wait for these areas to grow. If they're still glowing on the PET scan, can you zap them?
Mm-hmm. And I'd have to say, at least in our practice, our colleagues in radiation oncology, it really helps them to determine, which of the sites are, the optimal ones for radiation. So yeah, that's really been, I think, key in consolidating patients that I have on targeted therapy as well.
Okay, don't do that. Should our tumor markers be monitored regularly? So Dr. Schenk and I disagree on this. So I check blood-based serum markers at the same time I do scans. If I'm doing CT scans, and if there's a trend upwards, I fear the CT is missing something. For example, deposits in the bone or lymph nodes don't show up so well. And then I do a PET scan. If you're doing routine PET scans, you probably don't need them. Dr. Schenk has a different opinion.
Yes. Some of my thinking about patients with ALK-positive lung cancer is trying to maintain their quality of life. And part of that, in my view, is also mental health. And the reason I say that is that having blood draws that are just, it feels like every blood draw is a referendum on how you're doing via some of these very non-specific tumor markers. Now, absolutely, there are patients where their tumor activity is correlated with these non-specific tumor markers like CEA, but sometimes those can go up for a few points, and it is not related to tumor activity. And so in my practice, what I've seen is it really adds to the angst and the worry all around, scan review and meeting with your doctor. So I predominantly rely on scans for, to assess how well a targeted therapy is doing.
Okay, we got some other questions that are related to that. At what point can you reduce the frequency of scans? You have a thought on that one? Or what is your normal frequency of scans, and then when do you change it?
Yeah, it varies. And I think I also take some cues from my patients as well. And so initially, when a targeted therapy is first started, it's pretty on the dot every 3 months, whether it's a CT scan plus minus MRIs or PET scans based on how to best visualize the disease. But initially it's about every 3 months. And as we get a little more comfortable and get better, a sense of disease control over time, then I'm comfortable with starting to extend out the intervals. I think for some patients, we go to 4 months, some patients it's 6 months. But those are kind of the, sorry, technical issues, folks. That's kind of the extreme in my practice. How about you, Ross? How far do you feel comfortable extending scans?
I had this conversation with someone just the other day. So I do it in a stage kind of way. I mean, on the one hand, as you're doing better, I do sometimes extend it out to 4 months, occasionally 6 months. Same with kind of, brain scans. But you've got the other side of the equation that the more time that goes by, the more time for acquired resistance to occur. And so I would say I wouldn't go beyond 6 months, and I'd probably start to lose sleep at 6 months.
Yeah, I get worried that the window of opportunity would be lost to consolidate with radiation.
We don't need to see a picture of ourselves. We're just figuring out how to see your questions. Okay, let's see. what do you recommend when resistance to lorlatinib is occurring?
Hmm.
This is good because I read them out and I have thinking time and then I just pass it to you. Maybe you should read them out next time.
Okay, so I would say in the question of with lorlatinib resistance, definitely a repeat biopsy, which to better understand, what mechanism of resistance to lorlatinib, excuse me, is occurring. Is it something where there's an additional readily accessible agent where I could place a patient on in combination with lorlatinib, or is there, some sort of clinical trial where I could match a patient to an alternative therapy? But in the absence of those, that's when I think about clinical trials like antibody drug conjugates or even chemotherapy as the next step, depending on how the patient is feeling and what's available.
Yeah, I would agree with that. I think the rookie mistake would be to assume that you just need another ALK inhibitor, because if your mechanism resistance isn't another mutation in ALK, then a fourth generation ALK inhibitor will not be your answer. So if you rebiopsy and you reanalyze and you find a second driver, you're adding something in. If you don't find anything, your options are to add in chemotherapy. That's slightly controversial. Do you swap it out for chemotherapy? I actually add in the chemotherapy. And then there are other clinical trials. Dr. Schenk mentioned antibody drug conjugates. And there the issue is, I think clinical trials in the future are going to be, again, you're staying on the TKI and you're adding in the antibody drug conjugate. Many of the trials at the moment are written not thinking about oncogene-addicted lung cancer and where you just swap it out, but we're trying to change that. Do you want to read one out?
Sure, but I feel like I want to pick out one that's really challenging,
Yeah, go
but
for
anyway, I'll just
Like
go to the
that
next
like
one.
that one?
Is there a trial for consolidative therapy in Denver?
No, because we shamelessly believe we are right and we just do it. Just terrible arrogance there.
Okay,
Yeah,
well,
beat that one.
Let
Come on.
me try another one. Let me try
We should have
another
a
one.
show.
We tried to have a show, but they pulled the plug.
No, we didn't make it to the second season.
We did not make the cut. Let's see. What tips do you have for getting PET scans covered by insurance? What do our oncologists have to submit?
Tell them that your tumor marker is going up and the CT scan is normal. Beat that.
I can't. I can admit it when I'm beat. Okay. So here, I think this would be a good discussion. If you have a TP53 mutation, do you recommend to do anything now?
No. There is one very rare TP53 mutation, which I cannot remember the name of, but there's only one and it's super rare. It's like 2% of TP53 mutations, but 2% of TP53 mutations where they have developed a drug which actually works on it. But the vast majority of TP53 mutations, it's kind of that's the card you're dealt.
And I think the trial is already open, and this is in the EGFR mutant lung cancer space, where if patients at diagnosis have an EGFR mutation and a TP53 mutation, they're putting the EGFR TKI plus chemotherapy together at the outset to see if patients do better on that combination for a time than just the TKI alone. And I think that will be interesting to see, and we can kind of try to apply it to some of our other patient populations.
But that's just using TP53 as just a higher risk factor. So maybe we need to be more aggressive. It's not anything targeted specifically to the TP53.
That's a good clarification.
Okay. Can I read one out?
Please.
Okay. If you are NED, no evidence of disease, on a TKI, tyrosine kinase inhibitor, would you recommend staying on that until resistance or checking out a clinical trial before resistance? So NED, I should have to tell you, is not routinely used in medical practice. It's a kind of badge of honor for patients, but it doesn't actually change what we do. I think it would be hard to enroll in a clinical trial with NED because they would say, how are we going to evaluate? So I suspect you should just pat yourself on the back and sit pretty. But what do you think?
I think so too. In the sense that hopefully the the patient who's having, a great response to targeted therapy stays on that for a really long time. And so even if you were to start investigating clinical trials, you might start investigating, but it might close or finish all of its accrual by the time you might even need it. So I think waiting until you see some changes on your scan.
There's a kind of related question here. My mother is NED in the last 2 PET scans. We started alectinib last January. Shall we do consolidative therapy in the 2 previously active lymph nodes?
You
need thinking time.
I've already started to stutter something out.
Okay.
So again, I think this is another great point in time to, just celebrate the successes and how well your mother is doing. And that's fantastic. If the previously active lymph nodes, I guess, in my opinion, if they're no longer active, that they're suspicious for residual cancer, it makes sense to hold that radiation therapy sort of in your back pocket to keep it for when maybe there is activity seen.
I think that's true. It is a question that's gone through my head, because usually when you're NED, if it's disappeared, the radiation oncologist doesn't know where to aim it. Mm-hmm. However, a lymph node is an anatomical site. I mean, it's shrunk down to what was already there, and you can still see it. So you could be proactive, but equally, you probably got time to just sit tight and wait, because it's likely to come back in that area. And if you just pick it up, you could do the oligo-progressive therapy as opposed to the oligo-residual therapy. And again, you'd have to weigh up where that lymph node was located and the potential side effects of radiation, etc. Do you want to read one out? Scroll. I don't even understand that question.
Which one?
Well, don't read it out if I don't understand it. That one. Do one that I can at least answer. Doctor, how about this one? This is to you.
I'm just, so there is a question to me specifically about discussing some of the findings that we observed in blood-based studies on people who start targeted therapies. And the question is, can I explain further? Do people have more lymphocytes, which are a certain type of immune cell, like T cells, B cells, NK cells, and less neutrophils? And then a question about the neutrophil to lymphocyte ratio important, or monocyte to lymphocyte ratio important. Thanks for the question, Jim. I am very interested in how we can assay and look at the immune system in patients with ALK-positive lung cancer to try to start to figure out an immune signature as to who can do really well on targeted therapy. And I think we have some really interesting preliminary data that suggests there is an immune signature that can help even before targeted therapy is started, tease out who could have a really great run on a specific TKI and who might not do as well on that TKI. So in general, what's known about cancer, and this is true across multiple types of cancers and studies that have been done, is that if the system is at a certain point where it is there seems to be more innate immune cells. You talk about the neutrophil to lymphocyte ratio. The neutrophil is an innate immune cell. If there seems to be more of those predominating over the lymphocyte, that portends not as favorable outcomes versus if there tends to be more of the lymphocytes than the neutrophils. And my hypothesis is this actually reflects what's going on in the tumor microenvironment, meaning if you see some sort of disturbance of the normal balances of the immune system in the peripheral blood, this also reflects some disturbance of the normal balance, or I shouldn't say normal balance, but some sort of mechanisms within the tumor microenvironment that are causing the T cells not to be able to get in there as well and eliminate cancer cells. So the ongoing work is to try to connect these blood markers, not only with patient outcomes, but also with what's going on in the tumor, anticipating that I can one day do a blood draw, figure out what's going on within the tumor, and I can say, I need to start you on TKI and a neutrophil therapy, or I need you to start you on a TKI and this brand new T cell therapy, for example.
It's funny as you said that. sometimes said with these things, you have to figure out the mechanism and how you intervene, because it's not enough just to say you're going to do well and you're going to do badly. But if you genuinely could predict with very good accuracy who was going to do well and who was going to do badly, even that would have value, because then that could influence your frequency of scans and whether you do need consolidation radiotherapy. But it has to be a fairly good prediction, not just you're going to do a little bit worse on average. Okay, I've got one here. Let's see, if you have pre-existing mental health issues such as bipolar, should you worry about lorlatinib? And the answer is yes. You are more likely to manifest the central nervous system side effects. One of the key things with lorlatinib is the prescribed dose is 100 milligrams. And there aren't many people I know in academic centers who actually start people on 100 milligrams. I actually start people on 50, so they come in 25 milligram pills. Other places start at 75. And then, when do you go up? Well, if you're doing well, you don't have to go up. But if I was going to go up, I would leave at least 2 months, because sometimes the side effects can take some time to manifest. So again, the rookie mistake is starting on 50 and then 4 days later going up to 75 and next week going up to 100, because, the snowball is still rolling down the mountain at that point. You don't get to answer that one. I did that one for you.
Thank you.
You're welcome. Well, you did a really long one on the other one.
You're right. You're right. I have not been fair to you, and I'm sorry.
Do you want to find one?
Yeah, absolutely. Oh, this is a great one. This is a question of have you ever had a stage 4 patient who benefited from surgery? And so I definitely have in my clinical practice. And it comes around the time when we're seeing the maximal response on targeted therapy. And occasionally when the maximal response happens, or perhaps there's one disease site that is progressing, sometimes surgery actually makes more sense than radiation. So in an example patient of mine where the tumor wasn't a nice solid nodule for radiation to aim at, it was more of a semi-diffuse involvement of part of the lobe of the lung. And so in that situation, and this is not common, it tends to be mostly radiation, but in that situation, because of how fit the patient was, other clinical factors, surgery made sense. And so I've had a couple of those cases where surgery makes more sense and it's more because radiation therapy might not be as effective as we'd like it to be.
I want to do this one. Okay.
Please.
It says, in England, oncologists do not automatically do another biopsy. What can we do about that? So as you may or may not be able to tell from my accent, I actually grew up in England. My family is actually from Scotland. But I trained in Britain for many years before I came to America. One of the issues is it's a single payer healthcare system. So somebody's got to pay for the biopsy. They've got to be able to do the reanalysis, and many of the labs in the UK won't be able to look for ALK mutations, and they're hesitant about sending out to a third party such as Foundation. And also they may not have access to next generation drugs or ability to give drugs in combination. I think what you can at least try and do is be informed and have the conversation about, hey, this is what you can do. And so the British oncologists have to essentially be your advocate and lobby to the people above them to say, please, can you pay for that? And it's a tough and thankless job, but you can at least help them with showing that you're interested in that and, help them find the relevant information. Oh, there's lots of questions. We've got 6 minutes to get through 40 questions. Do you want one? What is the implication of having the reciprocal of ALK EML4 translocation in addition to having the standard EML4 ALK translocation? So, Lisa, I am sad to say I do not think there's any significance whatsoever. And I know there are nice publications out of China suggesting that it was associated with different outcomes, but I think that reciprocal occurs, you get 2 pieces of DNA that join together, and by corollary, you don't have other things floating around so that you get the other side. Whether you find that or not in the blood, I don't think actually matters. So you choose one.
I think this is an interesting one. What does it mean if an ALK fusion shows up on a liquid biopsy while on an ALK TKI?
you want me to answer that?
Yeah,
Okay.
I'm going to think.
Okay. All right. So let's assume that you were having liquid biopsies and you didn't see it, and now you do see it. That would be evidence of progression to me. That is a high-tech tumor marker, I would say.
Mhm. What if there's a situation that a patient gets a liquid biopsy, but historically nothing previously, but you can detect it?
What? I don't understand. Isn't that what I just said?
No, I mean, you don't have the previous reference.
Oh, you mean
points.
like
Yeah.
suddenly the first one, it's
Yeah.
there. Well, it means you don't have complete control of your disease. If you just started on therapy, the question is it going down or up?
Mm.
So I think if you've already been on therapy for 2 years and you can find it in the blood, that makes me think that something is going to emerge. If you're 2 weeks into therapy, I would sit tight and see which way it's going.
Thank you for all the questions, everyone. We're doing our best to kind of find the common themes here.
Ross, how do we do more international collaboration? Denver and Edinburgh working together, perhaps? Well, you got to send me a good pitch. It's as good, easy as that. I like to be collaborative. I do think so. This always frustrates people, but I kind of see it from both sides. So, why would an oncologist try and keep all their information to themselves and not share it? And the answer is because we're in this hotly competitive academic field, and your promotion and your salary may be influenced by whether you're get a publication or where your name is on the publication. That depends on whether you're perceived as, the sole owner of the information. I realize that for a patient, that's complete BS. And it's like, guys, get your act together. And as I get later in my career, I become much more sympathetic to the second argument. So I do believe there is more in collaboration, and I think there should be more to research than egos.
Definitely. And I think we should engage our industry partners as well.
The other thing what we should do is we should engage our universities to change how we value. I think you should get points for collaboration and not just for being, the be all and end all on the paper.
There's some questions on the question and answers too, but we'd have to make this.
Well, we have enough questions here to
Yeah.
sink a ship, Would you ever revisit previous TKIs for a patient? I'm exhausted all 5, but it's been over an 11-year time span and most work for a couple of years at a time. Just curious if the cell memory stays. So the usual answer is no, if you have stayed on a TKI throughout all that period of time. If you have had a break from TKIs, for example, a long period of time on a chemotherapy, you've changed the environment and you've selected out something resistant to the chemo, but not the TKI. But if you're on the TKI, usually you don't go backwards, assuming that they have gone in progressively broader and broader active TKIs.
So here is one. Some doctors suggest that a patient should start with the most powerful available TKI, currently lorlatinib, to guarantee longer PFS. In a case, a patient started 6 months ago with alectinib with great results. Do you recommend switching to lorlatinib anyway? I'm going to take a page out of the good Dr. Camidge's book and say no.
Yeah, I'd say no too.
You're doing, hopefully that the patient sounds like is doing fantastically well on the current therapy. You have the lorlatinib available, in reserve when progression starts happening. And then of course, when maximal response occurs, talking with your team about, is consolidative therapy, possible for what's seen on the scans.
Let's give you an analogy. So let's say you have sinusitis. Do you take the amoxicillin that your GP gives you, or do you go into the hospital for intravenous antibiotics? Well, usually you just take the simple thing and then you'd escalate as needed, especially if it had more side effects. We're allowed one more question, I'm told by the boss, who you can't see sitting to my left. Do you want to choose a really good one?
I think this is an interesting one because this might be part of our practice more regularly soon. And the question is, should we be requesting a liquid biopsy for monitoring at regular intervals? If so, how often? And there's quite a lot of activity, in the translational space with minimal residual disease and looking for cell-free DNA to try to get a sense of how well whatever therapy a patient has started on has cleared the tumor cells, as indirectly measured by the level of basically tumor DNA that can be directed in the blood. So I think this is a space to watch and see what starts coming about. I know that occasionally, with regular liquid biopsy monitoring that we have now available commercially, sometimes cost issues can come into the discussion. So I think for right now, I try to get a liquid biopsy when I'm worried about progression, maybe based on scans, to for most folks avoid some of that financial constraint issue.
Yeah, I also think that most of the commercially available liquid biopsies are not sensitive enough to really tell you when progression's going on, other than when it's sort of screaming at you. So I don't think they're a very sensitive early warning marker. They do have a value if you know there's progression going on, maybe to characterize it. But, I would say, I don't know, 50% of the time you don't see it in the blood. So it's kind of value if you see it and not otherwise. The bing bong went, so we may have to go.
Mhm.
Okay.
Thank you both for joining us
Thank
today.
you.
Okay, thank you.